You're going to encounter jaundice a couple of times in this course. Once in gastroenterology, once again in surgery, which is a duplicate, and then again in pediatrics when you talk about pathologic jaundice. That is the workup for direct hyperbilirubinemia. In this lecture, what I want to do is give you an approach, sort of cover the highlights of that medicine topic, point out the differences between pediatric jaundice and adult jaundice, specifically cancer and gallstones don't happen in kids, and then go over what's special about bilirubin in kids. And then finally, we'll talk about a differential or a pathway you can use to figure out why is baby yellow. Let's start off with that general approach. So the way we get jaundiced, that is the yellowing of the skin and eyes, is bilirubin. And bilirubin comes from red blood cell turnover. And this is sort of how I see the biliary or the bilirubin processing system. Bilirubin comes through the bloodstream, that is prehepatic, and is brought to the liver. There is a step where unconjugated bilirubin comes into the liver, a step where it gets conjugated, and a third step where it is excreted into the biliary tree. Therefore, you can look at this as prehepatic, posthepatic, and intrahepatic. And this correlates nicely with the type of bilirubin. Red blood cells turn into unconjugated bilirubin. And the rate-limiting step of the process of bilirubin is, number 2, the conjugation step. Compressed your attendings, 2,3 UDP glucuronal transferase. You don't actually need to know that for the test. Prehepatic jaundice brings the liver an unconjugated bilirubin. Unconjugated bilirubin comes from red blood cell turnover, and that can be either hemolysis or hemorrhage. In the case of a neonate twinning, you might also get a twin-twin transfusion. On the other hand, posthepatic is usually about obstruction. All of the bilirubin has been conjugated and excreted to the biliary tree. So a post-obstructive jaundice is going to be primarily conjugated. And conjugated bilirubin usually means gallstones and cancer, but kids haven't been alive long enough to develop either. So if you see a conjugated or direct hyperbilirubinemia in a child, especially in an infant, you should think of things like biliary atresia, sepsis, and the weird metabolic derangements. Bad stuff, basically. When it comes to intrahepatic disease, it becomes much more difficult because you can see there's a step that causes uptake, conjugation, and excretion, and so it depends which one you break. To keep this simple, what I want you to see is that hepatic is probably going to be a mixed picture. And this is where you're going to encounter the genetic diseases. In adulthood, we usually say, yeah, they just turn yellow under stress, but they live this long, no big deal. In kids, you might find a child who has a very high bilirubin and dies of this disease, or you're going to find someone who's not that high, and they grow up to be that kid that they turn yellow when they get stressed. But the names of the diseases become relevant in pediatrics. For example, Crigler-Najjar and Gilbert's are disorders of uptake, and these look very similar to a prehepatic jaundice, whereas Dubin-Johnson and Roeder's have a problem with excretion and look more like conjugated. And then there are the hepatitis. And I don't mean an acute viral hepatitis. Most kids are immunocompromised. And if they get infected with a viral hepatitis, they're likely to become a chronic carrier state without any acute inflammation. What I mean to imply is that if you have damage to the liver, you might see the liver enzymes rise. see the jaundice video in medicine, as well as the obstructive jaundice video in surgery for more details. But pulling this towards kids, what matters more is kernicterus and physiologic versus pathologic. Let's talk about the different types of bilirubin first. The D-bili, the direct bilirubin, also called conjugated, is the, quote, good one to have in the sense of kernicterus. Conjugated bilirubin has a charge, and so it becomes water-soluble. In being water-soluble, it cannot cross through cell membranes very well. So when it is excreted in the urine, it is trapped in the urine, and it turns the urine dark. But more importantly, because it is water-soluble and it cannot cross cell membranes, it cannot cross the blood-brain barrier. And being unable to cross the blood-brain barrier, it cannot cause kernicterus. Now, kernicterus is a big deal in the developing brain because if bilirubin gets the basal ganglia, baby is screwed for life. Once the brain is developed, that is in an adult, it really doesn't matter what type of bilirubin you have. Contrary, indirect bili, or the unconjugated bilirubin, is the exact opposite. It is fat-soluble, and so can pass through cell membranes easily. So even if it is excreted by the glomerulus, it will not be excreted in urine because it will cross right through the membrane back into the blood, and therefore it does not turn the urine dark. But most importantly, it can cross the blood-brain barrier, and it can lead to kernicterus by depositing in the basal ganglia. Now, if you just looked at this chart, you'd say, well, conjugated bilirubin is the good one, right? Because unconjugated bilirubin causes kernicterus. Well, that's true in the sense of kernicterus, but the other way to look at this is physiologic versus pathologic. Pathologic is generally worse to have, being that it is a more severe disease likely to require surgery or result in death. You'll be able to separate this based on the onset, the time to resolution, the type of bilirubin, and how fast it rises. Physiologic jaundice takes time to develop. It sort of gets going and then starts to pick up pace. That is, the onset is usually after 72 hours. A healthy baby leaves the newborn nursery well, then turns yellow. The resolution will occur in less than a week. Everything's a little worse for preemie, so it's 2 weeks for preemie. And the bilirubin is usually unconjugated. And the rise isn't that fast. The rise will not be more than 5 points per day. The idea here is that it takes a long time to set on. They leave the nursery. And by the time they come back for their first visit, they may not be yellow anymore. That's a sign that it's physiologic. On the other hand, pathologic jaundice that you need to go looking for, is going to usually occur within the first day and will take much longer than a week to resolve, generally won't resolve without your intervention. This is usually a conjugated bilirubin, and the rise can be fast. The reason for this is going to be something is devastatingly wrong in the pathologic condition, atresia, sepsis, or weird metabolic derangements, versus overwhelming the normal system. Rate-limiting step is conjugation, so the fact that physiologic jaundice is causing the unconjugated bilirubin to rise makes sense. You just simply overwhelm the system, and then you can help alleviate it. But we know that kernicterus is bad, so the thing you need to treat is an unconjugated hyperbilirubinemia, and you need to get it to conjugate it. This step is achieved by putting a baby into a box with a blue light, a little mini tanner, and basically have the light conjugate that bilirubin. This is what you do when the bilirubin is high. You can do an exchange if the bilirubin is really high. Now I put high and really high here because it's based on a nomogram, how old the baby is, premature or not, etc. You will not have to commit these numbers to memory. Just recognize that there's two ways of treating baby. Blue light to turn it to conjugated, to get rid of the unconjugated to prevent kernicterus, or an exchange transfusion if it gets out of control. Knowing that this only works for unconjugated bilirubin in the sense that it's physiologic jaundice and you're just helping baby along till they get through it, versus somebody who's got pathologic jaundice, which is going to require more serious investigation and likely a surgery. So using this knowledge, when a baby comes in yellow, you've got a yellow baby, what do you do? Well, the first step, as we've discussed, is to determine the bilirubin. If you have conjugated bilirubin, this is a pathologic jaundice. We have more on this in congenital defects. Pathologic jaundice is going to require a workup. You might get an ultrasound to look at the liver and biliary tree, a HIDA scan after phenobarb, induction, look for causes of sepsis, and ultimately give up and say, okay, it's one of these metabolic or genetic diseases, this kid's screwed. But on the other hand, if it is unconjugated, it is physiologic, and you need to know where that physiologic error is coming from. The first thing to do is do a Coombs test. If mom's antibodies are attacking baby's blood, and we know what it is, that is, if the Coombs test is positive, it's isoimmunization. If it's negative, you're going to want to look at the hemoglobin. Remember, most physiologic unconjugated bilirubin is coming from hemolysis or hematomas. If the hemoglobin is low, this is likely an indication of hemorrhage, cephalohematoma. If the hemoglobin is elevated, they've got some form of transfusion. And transfusion can be twin-twin. That is, two fetuses share one placenta, and so there's one cord connecting the two, and one baby gives a bunch of blood to the other one. The one that gave the blood comes out scrawny but does better. The one that comes out big and plump does poorer because of all the blood and can't handle the bilirubin. We'll talk more about that in OB. But you can also get things like delayed clamping, or accidental maternal transfusion. Now, if the hemoglobin, on the other hand, is normal, you want to check the reticulocyte count. Because if the reticulocyte count is elevated, then you've got hemolysis. And chances are, if it's this early, it's going to be G6PD deficiency, pyruvate kinase deficiency, or hemoglobin SS disease. And lastly, if the hemoglobin is normal and the reticulocyte count is not elevated but baby is still yellow, you've got a problem with reabsorption. And because the diseases of reabsorption are so similarly named, people have trouble with them. That is breast milk and breastfeeding jaundice. Let's see if we can't separate the two. Both breast milk and breastfeeding jaundice are exaggerated examples of physiologic jaundice. There's actually nothing wrong with baby. You do need to intervene. And separating the two will help answer pathology questions. But effectively, they're the same thing. A physiologic response that just happens to be a bit much. So we want to compare breastfeeding to breast milk. Breastfeeding jaundice is usually a problem with quantity. Because baby is not being fed enough, the bowel function is going to decrease. This allows the bilirubin to sit around and then be reabsorbed. This almost always happens on day 1 through 7. And because this is a physiologic jaundice, it's going to be unconjugated. And all you need to do is feed baby more. Breast milk jaundice is a quality issue. For whatever reason, mom's milk inhibits conjugation. Enzymes in her milk are doing this. And so, if you inhibit conjugation, you're going to have an unconjugated bilirubin. This usually happens after day 7. What you need to do to fix this is keep feeding baby, but get rid of that inhibitory enzyme. So use hydrolyzed formula. Now, in reality, mom goes home day 3 with baby, comes back in for a 1-week visit around day 10. At some point between leaving and coming in, baby's yellow. How do you know which one it is? Ask some questions, but really it's about feeding baby more and feeding them hydrolyzed formula rather than breast milk. So while courses spend a lot of time on the difference, it's really the same thing. Exaggerated physiologic response that is treated with hydrolyzed formula. This was a lot, but it's really hard to get a bunch of questions out of this lesson. I want you to see the general approach to bilirubin, how it differs in kids, what you can do to treat unconjugated bilirubin, that is blue light or exchange transfusion, and then the workup, which begins with differentiating conjugated from unconjugated, that is pathologic from physiologic, and then doing some blood tests to help find out what the cause is. Lastly, closing with the difference between breastfeeding, not enough, feed them more, and breast milk, inhibitory enzyme, feed them formula. That is neonatal jaundice.